Hello, everyone. This is Dr. Isabelle Amigues, your friendly rheumatologist and host of the Unabridged MD show. It's such a pleasure today as I have a colleague and a good friend of mine that has agreed to come on the show. And you heard last week our interview. So Sarah was actually interviewing me, Dr. Stombaugh, sorry, was interviewing me. And we thought that we would continue this conversation, but this time I'm interviewing her. And we're going to go into a little bit more details about weight loss because that's really the zone of genius of Dr. Stombaugh. So, Dr. Stombaugh, would you please introduce yourself? Tell us what your background is so people can hear about you.
Yes, absolutely. Excuse me. Thank you so much for having me and for us to continue this conversation. There is so much overlap between the world of obesity medicine and rheumatology, so we've had a lot of fun talking. My background, I'm a primary care physician by training. I did family medicine for 6 years in the Chicagoland area, and our family moved cross country about 2 years ago now to Virginia. And it was at that time that I decided to open a weight loss clinic. And I have a private practice weight loss clinic in Charlottesville, Virginia. I do see patients throughout the state of Virginia as well as Illinois, where I'm also licensed. And I love to support people in understanding their health, reconnecting with their body. I have a podcast called Conquer Your Weight, and it is my goal to help everyone achieve their optimum health and weight.
All right. Well, thank you so much. That's so wonderful. So, last week basically we talked about the role of inflammation causing like the role of adipose tissue causing inflammatory issues that can cause inflammatory arthritis. And then we were starting to touch upon the newer drug for weight loss. In your experience as an experienced weight loss physician, tell us a little bit how it has changed your practice, and then maybe we can
Mhm.
go into what they are and which patients benefit the most from them.
Yeah, absolutely. So we're talking about the GLP-1 receptor agonist, which is a category of medications that's been around for a little bit more than 2 decades now for the treatment of type 2 diabetes. But it's really only in the last 10 years that we've started using these medications for the treatment of weight. And it's really wonderful because we are seeing there's this paradigm shift by which a lot of the medications that we've used for the treatment of obesity in the past can be helpful for treating and supporting weight loss, but they sort of work indirectly. Maybe they decrease cravings or they are a stimulant in order to increase the amount of calories that we're burning. And they can be very helpful and they serve some role. But the GLP 1s have really been a game changer in the field of obesity medicine because they work both. They're centrally acting within our brain as well as peripherally acting within our GI system in order to reduce a lot of the food chatter and cravings that we have. But they also have this role in our GI system where they slow down our digestion. Food stays in the stomach for longer, it moves through the intestines longer. We often will feel satiated, so that fullness signal will last longer for after meals. And so, for people who have really struggled with their weight, finding that they're having a lot of cravings, finding that, oh my gosh, I've done everything and it hasn't worked, these medications have been really amazing because they just get into the heart of that physiology that can be really out of whack when we have chronic excess weight and really help to reset it so that all of the diet and exercise and things that patients have been trying to do, they're able to do and they're able to see the benefit of those changes.
It's so interesting. Do you think there is a before and an after those drugs?
Oh, absolutely. So even in how we describe, so we look at weight loss medications, sort of officially they're called anti-obesity medications. And they are even categorized into first generation and second generation medications. And that is based on the amount of body weight loss that we see from those. So the first generation medications are things like phentermine, Qsymia, which is a combination of phentermine and topiramate, Contrave, which is a combination of bupropion and naltrexone, and then Saxenda, which is actually a GLP-1 receptor agonist, but one of the less potent ones. Those produce on average 5 to 10% total body weight loss. And that can be really clinically significant for patients. But interestingly, as we look at the newer medications like Wegovy and Zepbound, we're seeing 15 to 22% total body weight loss on average. And that's where we start to get into a place where at that 10% mark and beyond, We are seeing really significant improvement in cardiovascular risk reduction, improvement of blood pressure, improvement of diabetes, improvement of arthritis, improvement of all of these things that represents a major shift. And we're actually, especially with Zepbound and then some of the medications that are in clinical trials right now, we are starting to approach the territory of bariatric surgery in terms of effectiveness, which is really, starting to be able to continue to be a major shift in the field because bariatric surgery has a role and is really life changing for a lot of people. It's also a major operation. And so, if we can approximate that with a medication, I mean, it's just amazing.
Yeah. Yeah, I talked to a nephrologist several years ago, and he was like, this has the potential to change everything because it can be preventive of kidney disease. So
Mhm.
for them, maybe less dialysis patients, preventing of cardiovascular disease and so on. And it's really cool. And I do think, as we mentioned earlier, potentially preventive of more inflammatory arthritis and maybe cancer even, right? Since it's pro-inflammatory.
Right.
Okay, so we've learned about what they do, how they do it. We've learned about the before and after. Now, I'd like to talk a little bit about some of the risks that we hear about in the public media, right? Like in the public spaces.
Hmm.
We hear about there's two of them, gastroparesis that we hear, and if you don't mind
Hmm.
also discussing what that is, and then the second is the muscle loss. Can you touch upon those two main issues? And if you have any other issues that you like to talk to your patients about, would love to hear that too.
Yeah, absolutely. So I think with these medications, because they are acting directly on the GI system in order to slow down gastric emptying, to slow movement through the intestines, we know that there are side effects that are to be expected. So I counsel every single one of my patients that they should expect these side effects. And I find that for patients, these side effects can be very well managed. And it's something that is typically mild and typically decreases over time. So, the most common side effect is nausea. The food is sitting in the stomach a little bit longer, and there can be this feeling of nausea comes from that. I've had many, many patients on these medications, and I've actually never had a patient vomit from them. So, it does tend to be nausea. Some people feel really quite nauseated, but never, or certainly not in my experience, to the point of vomiting. It is important that these medications are started at a low dose and that they are slowly brought up. And if they're done appropriately and under the guidance of a physician, you can really make sure that you are managing those side effects as they happen. It is also common to have lower GI side effects like diarrhea or constipation. More common is constipation, but interestingly, diarrhea is often the flip side of the same coin as constipation. And so either of those things can happen. We know that dietary fiber can really support that. So whether that is directly consumed from fruits and vegetables, and whole grains, or whether that's even supplemented, we know that that can really make a difference in improving that. And again, patients, sometimes you've heard in the media about bowel obstruction because patients have such severe constipation. Again, it's absolutely possible. There's absolutely reports of that being happened or that happening. But we know that if you're working with someone with whom you're discussing your side effects and really staying pretty on top of it, that the risk of it is low. Specifically with gastroparesis, it's interesting because that is a condition where the stomach is not moving. It's sort of paralyzed, it's not able to digest food properly. And one of the things we know can happen is that when we have conditions like type 2 diabetes, there could be nerve damage that happens where we get nerve damage anywhere in our body. It's common. We talk about neuropathy, like tingling or decreased sensation in the fingers. When we look at gastroparesis, there is this freezing of the stomach that happens. And in type 2 diabetes, you can get neuropathy in the fingers and the toes. It could be even more progressive than that. We see visual changes, so retinopathy, where the vision is impaired. And similarly, the nerves can be impacted anywhere in the body. So it's common, maybe not common, but it's not unheard of to have something like gastroparesis, where the nerves that supply the stomach are um, not effectively able to contract the stomach, squeeze the stomach so that it can digest our food. And so, one of the things that we're thinking is that with gastroparesis, we are really seeing that patients who may have had underlying sort of pre-gastroparesis, we're already having it, that it may come out as a result of these medications. I personally do not think that these medications are causing gastroparesis. And for the patients who are using it, who are having nausea or constipation, as long as they are being managed Um, and potentially stopping, right? If they're finding that you're using these medications, that they're having really severe side effects, that is an indication to stop a medication. And so
Mhm.
that needs to be really properly done under the guidance of their physician. And so I think in the prescribing of it, making sure that you have that close relationship in order to review how your body is processing it is quite important. And tell me, there was a second half of the question that now I'm
The
completely blanking on.
muscle mass loss, so losing muscle.
Yes, absolutely. So I think this is really a very serious concern because when we think about losing weight, we talk sort of commonly about weight loss, but the reality is you don't care about losing weight. You want to lose fat mass.
Mhm.
And so it's very common as we lose weight that there may be some muscle mass that goes alongside of that. And a small amount of that is physiological. So if you imagine a 300-pound body, and if you imagine the amount of muscle required to move a 300-pound body through space, to walk up the stairs, to take a shower, to do all of your daily activities, there's a certain amount of muscle required simply to move your body through space and time. And so if you lose 100 pounds and you weigh 200 pounds, the amount of muscle required to move that 200-pound body up the stairs, through the shower, through all your day activities is going to be less. So there may be some slight decrease in muscle mass that happens when we're at a lower body weight, and that is okay. What we don't want is for there to be this disproportional decrease in muscle mass that can absolutely happen. So it's important that we're thinking about what is the caloric intake that we're having in general. Some people take these medications and have really significant appetite suppression to the point where they don't feel like eating at all. And we do need to eat some, and especially we need to make sure that we're eating protein. So most physicians will recommend to their patients that they have minimum protein requirements that they are getting throughout the day in order to support their health and their metabolism, so that as our body is looking for energy, if we don't have enough energy when we need those amino acids, our body can break down our muscles to make that for us, or it can have access to them from the food or drinks that we have that contain protein. And so, one of the most important things as we're using these medications, or honestly in general with weight loss, is that we are adequately supplementing and supporting ourselves with protein to make sure that we're having adequate support for our existing muscles and then continuing to build those. We also will usually recommend resistance training as part of this. So, making sure that you're doing weightlifting type exercises because one of my biggest concerns is that with irresponsible prescribing of this medication, if patients are given the medication without any guidance of how to use it, whether that means side effects, whether that means dietary advice, whatever, we may see that people lose weight, but if they lose their muscle mass, we're actually creating a condition where they are just as, if not more, unhealthy. So we think about obesity as our total weight. We talk about BMI a lot, but the reality is the best measure of obesity, sort of true obesity, is our body fat percentage. And so if we are finding that your body fat is not decreasing, it's actually maybe increasing in percentage because you're losing muscle mass, that will have really detrimental health effects. So I do think that that is a side effect that anyone taking these medications should be aware of and have a plan with their provider to make sure they're addressing that.
Mhm. What a good, thank you so much for all of this. I think it's so interesting. I was just thinking, as you're mentioning about the protein, protein fills you up a little faster than other
Mhm.
aliments. So how do you help patients who are trying to get protein, but at the same time they are nauseous and they don't really want to eat, right? It's almost like they are forgetting to
Mhm.
eat.
Right, exactly. So sometimes that means supplementing with protein. But a lot of times when we think about a meal, I think about we really have to be intentional about the way in which we consume our meal. And we really should be doing this in general, but especially on the GLP-1 medications where you have this major appetite suppression, you really want to be thinking about getting your nutrient dense foods first. And so if you only have so much room in your stomach, what are you going to put into it? And so thinking about protein and thinking about fiber are really the two things that you want to make sure are going into your stomach. And so, you can consume fat, that's fine. You can consume carbohydrates, that's fine. But if you're filling up on those before you get the opportunity to eat really good fibrous food, to eat really good protein, that is going to have really detrimental health effects. So making sure protein comes early, Usually I say vegetables first, protein second in a meal. So making sure that happens. And then for a lot of my patients, even supplementing with protein. So that may mean I really like protein beverages as an easy way to get it in. That can look like protein waters, that can look like collagen supplements. I really like bone broths as an excellent way to get both protein and then some collagen there. And then sometimes protein shakes as well. Although you have to be careful depending on a lot of those are artificially sweetened. Some of them are sweetened with sugar or high fructose corn syrup, which may sort of be beneficial from a protein standpoint, but create other issues alongside of it. And so you really want to make sure that you're having, if you're taking any sort of protein supplement, that there are clean ingredients in it.
Yeah, thank you so much. And then, so who is the ideal person to use those?
Yeah.
Because right now we're seeing a lot of people who want it, who get
Mhm.
it, even over the counter, or get it in different weird scheme on internet. Um,
Right.
like, who are the ideal candidates for this, and who are the candidates that probably should not be on it?
Mhm. So I think, the neat thing about this medication is that I think it resonates with a lot of people when they think about decreased food craving and that food noise. A lot of people are really plagued with, the plate of brownies calling them from the kitchen and just really constantly thinking about food and craving food and having these urges and that resistance. And so it's easy to see why it appeals to so many people. But the insurance companies, especially, have been really starting to crack down on, who are the people for whom this medication is indicated and for whom will we cover it. So, for one, there's not always great insurance coverage. It's going to be really dependent on the insurance company, on the employer primarily, whether there is or is not coverage for it. But we know these medications are FDA approved. So, one for the treatment of type 2 diabetes. Interestingly, a lot of these medications have been around for a while for the treatment of type 2 diabetes and then have gotten rebranded for the treatment of obesity. So, Ozempic, for example, is semaglutide. It has been rebranded as Wegovy, and that is FDA approved for the treatment of obesity. So, when we look at medications for the treatment of obesity, that is patients for whom have a BMI of 30 or higher, or patients who have a BMI of 27 or higher with obesity related comorbidities. So, that's things like high blood pressure, high cholesterol, maybe prediabetes, polycystic ovarian syndrome, arthritis, acid reflux, a lot of these conditions that could be related to our weight. We know that patients may be supported with these medications. Similarly, Mounjaro had been on the market for a while as a treatment for type 2 diabetes, has rebranded as Zepbound for the treatment of obesity. Again, follows those same criteria. So, generally, I am looking for patients who meet that criteria. I do think it's important to say weight is often a chronic battle for patients, and there's often this chronic medication. They need to use medications for long term. And if they've had success in the past with other medications, so maybe they've taken a pill or they've used other medicines or even bariatric surgery in the past and have seen weight regain, even if they don't meet those BMI thresholds, they may still be a candidate for it based on some of their other factors, based on their adipose tissue, for example. So primarily I am looking at patients for whom we're really going to need to see at least 10%, maybe closer to those 15, 20% total body weight loss in order to achieve the health outcomes that we're looking for. And so that is primarily what I'm looking for, in addition to, unfortunately, what is the insurance coverage. Those are going to be some of the primary factors to determine if a patient's a good candidate for these medications.
Okay, wonderful. And who are the patients that you will be like, no, this is really not a good idea?
Yeah. So sometimes people are looking at this medication as a short term, like, oh, I just want to take this medication, lose the weight, and then I'll go off of it. The way that these medications work, and maybe look at the role of chronic excess weight, it can be really challenging to think about them as short term. They're not really meant to be used in that way. In the way that if you had high blood pressure, for example, and your doctor prescribed an antihypertensive medication, a blood pressure medication, you would take that medication, you would see that your blood pressure would come down, and then we would say that you have well controlled hypertension. And so we would continue you on that antihypertensive medication. and you would continue to see that your blood pressure was controlled. But if we stopped your blood pressure medication, that antihypertensive, we would likely see that your blood pressure would go back up.
Mm.
And so these medications are really designed to be used in the exact same way. There are absolutely sort of one off stories, anecdotal data of people who start these medications, use them for a period of time, and can stop them and have really good long term success with their weight. But the reality is, it can be really challenging for people when we look at as a population. When people have started these medications, and they've been done both for Wegovy as well as for Zepbound, when you start these medications and use them for a period of time, in the studies, 20 to 36 weeks is what was studied, and then you stop the medication, what happens? And there's a really broad range, but most people will see regain, maybe not of all of the weight, but of a good portion of the weight. And so they are designed for long term use. So someone who's like, yeah, I just want to jumpstart it, I just want to use it for 6 months or 12 months, that's really not going to be the right candidate for these medications. Someone who has not a huge amount of weight to lose, especially depending on if they have done other if there's other areas that they could improve. If we're looking at their diet and seeing that there's really some great areas that we could make modifications, if we could improve their exercise regimen to include resistance training, for example, if they have not sort of maximized these other aspects of their life, layering on that medication, I never want someone to think of anti-obesity medications as an easy way out, right? We know that chronic excess weight has this chronic pathology, this pathophysiology that makes it really challenging for eating less and moving more, for those things to actually work in order to help us lose weight. So, using medications when you've had that chronic excess weight are absolutely not an easy way out. They are a tool in the toolbox. So, if you are someone who's like, oh my gosh, I've tried everything, I feel like I'm doing everything and it's not working, these medications work really well. And if there are other things that should be optimized, I really want to make sure that we're optimizing those things for people before necessarily jumping on these at first.
All right, that's so helpful. So thank you so much. While we are concluding this session, like this podcast, I wonder if you can tell where we can find you, and if you have anything else that you think we should add.
Yes, absolutely. So I think a lot of people are hearing about these medications on social media, on the media. They're intrigued, maybe they're scared, but there's a lot of conversation around it. And so I think if your interest has been piqued and you're like, oh my gosh, is this a good medication for me? I encourage you to ask your doctor, whether that's your primary care physician or maybe an obesity specialist. Go to
Mm.
them and say, hey, yeah, ask Dr. Amig, ask myself, reach out and ask, am I a good candidate for this medication? Because you very well may be. And these medications, when used properly, can be amazing, amazing tools. I'm happy to support anyone. I see patients throughout the state of Illinois and Virginia. You can find me on social media at Sarah Stombaugh, MD. I have a podcast called Conquer Your Weight, and I'm happy to share lots of evidence based sort of what's the real. There's all sorts of crazy stuff in the weight loss world. And so I love just cutting through all of that, providing real evidence-based care for my patients and for my followers. And so I'd love for anyone to come find me over on social media or at my podcast.
Absolutely. And we will have all of this information in the footnotes. So this concludes this two-part episode of the podcast. And I really hope you enjoyed it. I think that you gave us so many good information, Dr. Stombaugh. I mean, it was great. It's been really, really wonderful to have you. And until next week, everyone, and please subscribe, share this episode with someone, as you know, maybe someone needs to hear that. I think that there was a lot of very, very good information in this episode. Thank you again, Dr. Stombaugh, and see you and see everyone next week. Bye.